We are live on YouTube.
Okay, sir.
So we'll start in 1 minute. Is it okay?
Yeah, no problem.
Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 17C, which is Hematology, and we are dealing with malignant myeloid diseases. We are streaming live from CTC PHO BMT Borivali, Mumbai, which is Comprehensive Thalassemia Care and Pediatric Hematology and Bone Marrow Transplantation Division, Borivali, Mumbai, via Kolkata. A very interesting topic. This is the first session of Myelodysplastic syndromes. And to talk on that, we have Dr. Muralidaran C. He is an MBBS from the famous Stanley Medical College, Chennai, MD Pathology from P.G.I.M.E. Chandigarh, DM Clinical Hematology from K.E.M. Mumbai, currently working as Super Specialty Medical Officer at the CTC PHO BMT Borivali, Mumbai. He's got multiple international and national publications. Person who's an expert in myeloid and malignant myeloid diseases. Before I ask him to start, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Muralidaran sir, please share your screen and let's start.
You can see this.
Yeah, it's perfectly fine. Please start. Yeah.
Yes. Good evening, very good evening to everyone. First of all, I should thank Dr. Nadeem for giving me for this opportunity to present in this platform. So my topic is on myelodysplastic syndrome. So today I'll be talking in two sessions about this topic. In the first session, I'll be talking about the WHO subtypes, clinical features, and I'm going to talk about elaborately about pathophysiology that includes cytogenetics and molecular genetics, and we'll close the session with the risk stratification. In the session 2, we'll be talking about case-based diagnostic approach with differential diagnosis, morphology, including immunophenotyping, and a few slides about pediatric MDS as well as treatment. So the word myelodysplasia is came from Greek words. The meaning this means abnormal and plasis meaning formation, and it was first introduced by the FAB classification in 1982 to describe the morphological abnormalities of myeloid cell lines of hematopoiesis in pre-leukemic conditions. So in WHO 2001 has revised this FAB classification by integrating the morphological and genetic information into a working clinical tool, and after that it was revised twice, and the latest one was put forward in 2016 by WHO. And for prognosticating the MDS, an international working group for prognosis of MDS was formed in 1997, and they have came up with one prognostic score, and it was revised in 2012, and it is a very useful and very simple and reproducible tool for prognosticating the MDS patients. And most important of MDS aspect is the genetics of the MDS, and it holds key for the treatment and as well as the clinical outcomes. So we'll be discussing about elaborately about the cytogenetics as well as the molecular aspect of the MDS in today's session. So even though I told about the molecular genetics is very important in MDS, the morphology still holds the holds the card here, and is still relevant in MDS in today's field of advancements of in hematology. And why? Because it is an heterogenetic disease, and it has to be diagnosed with all aspects of hematology. That includes morphological test of bone marrow smears, including special stainings like iron staining. And we need a good hematopathology team to look forward the core biopsy to assess the cellularity. In some difficult cases, you might have to differentiate the hypoplastic MDS from the aplastic anemia. And even though flow cytometry is not required for the diagnosis of an MDS, but in recent years flow cytometry is coming up, and in difficult cases we can use it to define the cellular immunophenotype, and the maturation pattern can also be assessed for MDS. And of course, for diagnosis, cytogenetic data is required, and for prognostication, both cytogenetics and molecular studies can be used for risk stratification as well as for the prognostication. So, how do we define a WHO? WHO definition for MDS, and so to say MDS is a group of clonal hematopoietic stem cell diseases. It are characterized by cytopenias, dysplasia in one or more of the major myeloid lineage, and it has ineffective hematopoiesis, recurrent genetic abnormalities, and increased risk of developing into an AML. So WHO came up with several distinct subtypes of MDS based on the number of cytopenias at presentation, number of myeloid lineage manifesting as dysplasia, presence of ring sideroblast, and blast percentage in the peripheral blood as well as in the bone marrow. This is the table showing the WHO 2016 classification of MDS, and it has been classified as 6 divisions, and one provisional category also been given. And the first category is the MDS with single lineage dysplasia, where we can see only dysplasia in one of the series, and cytopenia can be present in 1 or 2 series at maximum. And the ring sideroblast will be less than 15%, and the bone marrow blast will be less than 5%, and peripheral blood blast will be less than 1%. And cytogenetics, they might have or they might not have, but if they're having other features, we can still diagnose MDS with single lineage dysplasia. In a multilineage dysplasia, everything will be same, apart from that people will be having MDS patient in this category will be having dysplasia in 2 or 3 lineages. And in ring sideroblast, with the ring sideroblast, we can divide it with the single lineage dysplasia, multilineage dysplasia, with the features of both dysplasia in either 1 or 2 lines, with presence of rings more than 15% ring sideroblast, and bone marrow blast being the same like MDS SLD or MDS MLD. And interestingly, we can see that the cutoff of ring sideroblast is even if they are having 5 ring sideroblast is sufficient when they are having a mutation of SF3B1. And another special entity, MDS with isolated deletion 5q, and it has dysplasia in predominantly in erythroid lineage, but it can also show other dysplasia in other lineages as well. And cytopenia can be present in 1 or 2 lineages, but bone marrow blast will be low, and they will have only deletion 5q abnormality. But if they can have allowed to have one more other abnormality, but except monosomy 7 or deletion 7. And other the higher classes of MDS that are termed as MDS with excess of blast, where we are divided into EB1 and EB2 depending upon the amount of blast in the peripheral blood and the bone marrow. And cytogenetics can be anything, but the bone marrow blast should be less than 20%. And other last category is MDS unclassifiable, where we are having cytopenia without any dysplasia, or dysplasia without any cytopenias, and they're having only MDS defining cytogenetic abnormalities, or a single lineage dysplasia with pancytopenia with any of the cytogenetic abnormalities has been classified under MDS unclassifiable. So another important thing to mention about that, the presence of iron rods, even if they are having 1% of blast with having a single iron rod, that will automatically go into MDS EB2. So this is the WHO classification, and cytopenia definition should be like hemoglobin should be less than 10 grams, and absolute neutrophil count should be less than 1800, and platelet count less than 1 lakh. So the WHO defines the dysplasia with some morphological features. They are described in WHO. To assess the dysplasia, we should have at least counted 500 cells in the bone marrow, and peripheral blood we should have counted at least 200 cells. And the features of this erythropoiesis has been given here, and even this granulopoiesis also given, and this megapoiesis also given. So I'm not reading out. Anyway, we are going to see in the next section about detailing about the morphology of MDS along with the cases, so that any student can easily absorb the teaching, so that I am not going through in detail. So coming to the epidemiology, the MDS is a disease of elderly. Most of the patients generally present at the elderly age, and if you see without age correction, the cases will be around 5 cases per 100,000 persons per year. But if we go towards decades, like more than 70 years, it has been shown it can even go up to 75 cases per 100,000 population. Having said that, even it can also affect the children, though rare, it can happen with its unique characteristics and diagnostic criteria. And apart from these myelodysplastic syndrome, there are other myeloid neoplasm that are related to therapy-related myeloid neoplasm that has been grouped as a separate entity in WHO. Apart from that, we are having MDS MPN group but since my topics on MDS, I am like not discussing too much about thyroid therapy-related myeloid neoplasm and MDS MPN category. And I just want to quote few things about therapy-related myeloid neoplasm, because it is very closer to the MDS and it has a more cytogenetic abnormalities. So for pathogenesis parts, like I'm like including some of the pathogenesis features of therapy-related myeloid neoplasm. And so the primary or de novo MDS is occurs without a known history of chemotherapy or a radiation exposure. So possible etiologies, they are attributing to previous history of any benzene or cigarette smoking and agricultural chemicals or solvent exposure, or any family history of hematopoietic neoplasm. And we know that some germline mutations including inherited bone marrow failure syndromes like Fanconi's dyskeratosis congenita are also having increased risk of developing into an MDS. And acquired aplastic anemia is also associated with increased development of MDS. We will also go through that in subsequent slides. So the MDS, we know that it is a myeloid neoplasm, and do we have any precursor conditions for MDS? I think so, we are having. So before going into that MDS precursor lesion, one should know about something called age-related clonal hematopoiesis. So we know that as age advances, there are somatic mutation happens normally in normal tissues. So rarely some of these mutations will have a selective growth advantage to the cell when it occurs, and it grows progressively, increases over time. So whatever the cell which increases in time, mutated cell increases in time, it's called clone. And if the clones happens in the hematopoietic stem cells, we call it age-related clonal hematopoiesis. So most of the mutations that are happening in age-related clonal hematopoiesis is involving the epigenetic regulations, mainly involving the DNMT3A, TET2 and ASXL1, also known as DTA mutations. So other mutations like other driver mutations like TP53, JAK2 and SF3B1 are very rare, but though they can also happen, but they are very rare. So what is the word CHIP means? CHIP is nothing but a presence of a similar type of mutations what we are seeing in ARCH without any cytopenia or without any diagnostic features of MDS. So any patient who are presenting with some amount of cytopenias and we are detected by doing a routine investigation, or as a part of a diagnostic algorithm, we have found out some clonality in hematopoiesis. So in those cases, like we can use the word CHIP. So ARCH and CHIP can be used interchangeably. And as we mentioned that CHIP mutations are like, as age advances, the amount of mutation also increases increases, and we can see that the patient who are like having more than 90 years of older, they have a percentage of around 18% CHIP mutations. So how a CHIP will progress when the CHIP mutation happens? So there are two types of mutations I should tell about. That there is something called passenger mutations or something called driver mutations. The driver mutations are the one mutation that will like progress a disease from one stage to another stage, and eventually it leads to the leukemic phase. So these driver mutations generally won't happen. Most of the mutations are happening are passenger mutations. So when these CHIP mutations, when they are having some driver mutations that mainly that involving like TP53 or other PPN, MDR, or any history of any exposure to chemotherapy or radiotherapy, that will like give the survival advantage for the mutated hematopoietic stem cells. Then eventually it will like lead to progress to the second stage, third stage, that's called clonal cytopenia of undetermined significance, or it can evolve to an MDS or AML. That depends upon the mutation profile and the mutation burden. So this is the table showing the different precursor lesions of MDS and their association, and we will be like talking about in detail. So the first one is called idiopathic dysplasia with undetermined significance. So we can see that idiopathic dysplasia, we don't know why the dysplasia is happening, and there will be some amount of dysplasia will be there, but there will be no chronality, there will be no cytopenia. The bone marrow will have a blast percentage less than 5%, and they have a very low risk of developing into AML or MDS. And genetic abnormalities, there will be no genetic abnormalities. So the next stage is called ICUS, where it is defined as idiopathic cytopenia of undetermined significance, where we have only cytopenia without any dysplasia or chronality, and they have very low risk of developing into AML, like say less than 10% at 4 years, and they do not also have any typical genomic abnormalities of MDS. Coming to the next stage is called ARCH or CHIP, where we will have chronality, but we don't have any cytopenia, dysplasia, and there will be no increase in the blast in the bone marrow, and they have a risk of developing into AML or MDS at 5% at 7.5 years, and they will have typical VAF is variant allele frequency, that is the clonal burden, mutation burden, that will be present at least 2% in the gene. The common mutations, as we mentioned before, DTA mutations are very commonly seen in the CHIP category. Next phase progression is CCUS. CCUS is clonal cytopenia of undetermined significance, where we will have, apart from cytopenias, we will have clonality also, without increase in the blast in the bone marrow, and they have more mutation burden, at least 20%, and they have mutations apart from DTA mutation. They can also involve some spliceosome mutations also, but without any MDS defining cytogenetic abnormalities. So they have more risk of developing into an AML or MDS at 70% at 4 years, and so when we compare to the MDS, the CCUS are like considered to be a low risk type of MDS, and that higher risk of MDS will be like definitely having more mutation burden, more than 30%, and they will have all the features of chronality, dysplasia, and cytopenia, though the blast will be like less than 20% in the bone marrow. So several there are several mutation driver genes belonging to different biological pathways that will lead to ultimately to MDS. So there will be combination of these pathway mutations that accounting for the heterogeneity of these disorders. So another cartoon to show the relationship between the chronality, dysplasia, and the cytopenia. So we can see that there is interplay as well as overlapping of these conditions, and if they are having all these three, that will be like presenting as an MDS. If they are having only chronality without cytopenia, dysplasia, they will having ARCH, or they will having only cytopenia without chronality or dysplasia, they will be called ICUS. If they are having only dysplasia without cytopenia or chronality, we will be calling as IDCS, that is idiopathic dysplasia of uncertain significance. So what is the problem with this CHIP and CCUS are because it is not only present in the MDS patients, but it can be present in the aging population also, as we described that these CHIP mutations are also present in the normal aging population. So in any patient with cytopenias without any MDS defining morphology or a cytogenetic abnormality, we should definitely exclude a non-neoplastic etiologies like nutritional deficiencies, alcohol, or any other drug or infection effect. So how can you differentiate this MDS from these precursor lesions? Mainly, we can see that there are some MDS specific mutations, though they are not specific for MDS, but when they are having spliceosome or epigenetic regulation or TP53 mutations, and along with that, if they are having more than 2 mutations with at least 30% WAF or symptomatic cytopenia with MDS defining morphology as cytogenetic abnormality, then we can of course differentiate the MDS from the CCS. So now we are like convinced that this CHIP and CCS are definite precursor lesions for MDS. By definition, CHIP should be like having a normal peripheral blood cell counts with a somatic mutation, and the variant allele frequency, that is a WAF or we can say mutation burden, should be at least 2%. And when compared to CCS, the next stage of the disease, there's a clonal cytopenia of undetermined significance, where apart from we are having this mutation, we will be having unexplained cytopenia in one or more peripheral blood cell lineage, and these mutations should be like having at least 20%, and but they will have insufficient WHO criteria to diagnose an MDS. So coming to the main part of this lecture about the pathophysiology. The pathophysiology, the first phase, it happens in 4 phases. So the MDS, we know that it arises from the it's a stem cell disorder. So first thing will happen, what happens, there will be initiating a driver mutation occurs in a hematopoietic stem cell or a progenitor cell, any cell. So it happens in the bone marrow of any bone. So it will lead to increase in the size of that clone, and it will be like progressing. This is the first stage. So any driver mutation, they will discussing in subsequent slide about the mutations, and this mutation will happen and the clone size increases. This is the first stage. In the second phase, the formation of so-called CHIP, that is a clonal hematopoiesis of indeterminate potential, where the clone size increases in number and also spreads to the other bones through the bloodstream. So it so not only a single bone, there are multiple bones will be like having these clones, and these migrated mutant stem cells will colonize the other bones and they will increase in size. So in this stage, we will be like having mutation even in the peripheral blood, but if we see the clonality, we will be like having around 2 to 10% at maximum. So these, what are the mutations happening in this stage? Mostly involving the epigenetic regulators like DNMT3A, TET2 or AXXL1. Very few will have a spliceosome gene mutations. So when anybody is having a spliceosome mutations at presentation only, so it is an indicator that they will like progress to the MDS or third stage, that is called CCS phase. So in third stage, we are having that MDS or CCS phase. Here we will be like characterized by the clonal dominance. So whatever the bones which are having these clones, that expands progressively and they becomes dominant in the bone marrow, and this process is like a commonly associated occurrence of additional somatic mutations, and the median number of mutations also increases. Say before it is 0.1 to 1, now it increases to 2 to 3 per mutations, and the clonality to be considered to be like in this phase, we should have at least a WAF of 20%. So when these driver mutations happens, whatever genes cause these mutations, that will lead to clonal outgrowth, and there will be propagation of myelodysplastic hematopoiesis. When there is clonal hematopoiesis happens in the bone marrow, and the bone marrow cells are totally like formed with these clonal cells, that will lead to the ineffective hematopoiesis, and most of the cells will die in the bone marrow only. So we will have peripheral cytopenia, we will have dysplasia, and apart from we will have increased bone marrow cell that is hyperplastic bone marrow. So when it sometimes if they are having associated some inflammatory lesions or like increased inflammatory conditions, they can also lead to hypoplastic MDS, that will be discussing in subsequent slide. So when this clonal outgrowth of this mutant stem cell is also favored by an abnormal hematopoietic stem cell Nike, and this alteration of stem cell Nike is predominantly caused by the aging population, and that's why the MDS is more common in elderly patient, because of the aging thing. The alteration in the stem cell Nike will lead to clonal outgrowth of mutant stem cells, leading to the MDS. And there are also involvement of innate immune system and related inflammatory signaling between this mutant hematopoietic stem cell and the stem cell Nike, that also lead to the outgrowth of this mutated clones. So because of these combination of mutations and molecular mechanisms, it will lead to genetic diversity during the progression of the disease. Because of this, multiple genes are involved, so becomes very difficult to treat. Sometimes even they becomes also resistant to therapy also. So how the clonal evolution happens? So we know that this MDS having gene, it's very heterogeneous. There is no single mutation present when a patient is having an MDS. So as I mentioned before, so most of the patients will be having so-called ancestral or passenger mutations that may persist asymptomatically even for a longer period of time. So when clonal evolution happens, when we are having a gene mutation or cytogenetic aberration over a ancestral or passenger mutation, that may lead to a development of a newer clones or an expansion of a previously ancestral clones. So each clone will carry forward all the pre-existing driver or passenger mutations, and that will lead to a genetic evaluation, clonal evaluation. So sometimes one clone can overlap with or totally replace the original ancestral clone, and that can lead to disease progression and also determines the phenotype of the disease. So when it finally a clonal evaluation happens, the bone marrow is replaced with totally clonal cells. The next stage will be like a progression to a leukemic phase, where it's characterized by presence of blast, which is more than 20%. And this evolution to AML is a process of a clonal selection which occurs in both linear pattern as well as branching pattern. And how it happens? It happens because of an addition of an additional somatic driver mutations. This mutation happens at the stem cell level or progenitor level, that gives to self-renewal capability, and also because of the acquisition of additional driver mutation lead to impaired differentiation capacity. So the leukemic transformation can also have the mutations that driving the leukemic transformation can be present even at the earliest stage of the disease, or it can present at the later stage of disease. It depends upon what type of mutation we are having. For example, if you see in SF3 mutated MDS, it has a very long-lasting chronic phase. The mutation as itself is a low-risk case. So it won't progress to MDS unless if we are having our acquisition of another mutation that commonly involves RUNX1 or EZH2, that will lead to the progression of the disease. So if we compare with the other MDS, high-risk MDS, which involves Spliceosome or cohesive mutation like STAT2 or RUNX1-2 or EDH2, they will have an early progression to AML, and they are characterized by excess of blast even at the onset of the clinical disease. So we can clearly see a progression of an MDS to an AML in these type of cases. So that's how about the pathophysiology. The pathophysiology happens at 4 phases, as we told. So first, the formation of the clone, and the second phase is the formation of the chip, the clonal hematopoiesis, and it progresses to other bones. And the third phase, the CCS phase, where the clonal dominance happens. Bone marrow is totally filled with clonal cells, and you will have cytopenias, dysplasias. And the fourth phase, when other mutations also, when driver mutation acquires, it will lead to leukemic transformation and clonal evolution. So this is how pathophysiology of MDS is described, and it has been it's a stepwise process, or it can be occur at early stage also, and progression also can happen at the late stages also, depending upon the type of mutations. So coming to the clinical features of MDS highly non-specific to say. It depends upon the MDS subtype, and it can ranges from indolent to life-threatening symptoms. Most of these symptoms are like related to the cytopenias. Most commonest symptom is the anemia, which will generally patient presents with either fatigue or breathlessness. In some in one third of the patients can also have neutropenia and thrombocytopenia. So they can present with unexplained infections and bleeding. So whenever they are presenting like that, you should always suspect an high risk MDS. And so apart from this, one third of the patients also becomes transfusion dependent at diagnosis. So they will be requiring more blood transfusion, and because of more blood transfusion, they will be landing up with transfusion related morbidity. And some patients can be totally asymptomatic, but they may have cytopenia. In those patients, we have to follow up very closely. So who do you suspect an MDS? So any elderly patient with an isolated unexplained anemia or an unexplained progressive cytopenia, or any history of exposure to environmental toxins or chemotherapy or radiotherapy, we have to have a high index of suspicion in these patients for MDS. So now we will be talking a little bit more in detail about mutations in MDS, because the treatment, risk stratification, and also in future exploration of risk and prognosis depends upon how we can understand the mutations in the MDS. So there are more than 100 genes have been recurrently mutated in MDS. The most common are like these 5 mutations that has been bolded here out. The SF3B1, TET2, SRSF2, ASXL1, and DMT3A. And there are other 10 to 15 mutations which are also commonly present, but they are in range of around 5 to 10% of the cases. So these mutations are not common for MDS, or not specific for MDS. They can also occur in other myeloneoplasm that includes AML. So, but having said that, some mutations can be present in higher range in MDS, and some can be present in almost like an AML, or one can be like present increase in AML or an MDS like that. We will be describing further slides. And in comparison to non-hematopoietic malignancies, MDS has fewer somatic mutation. And we also know that certain germline mutations like RUNX1, GATA2, DDX41 are also associated with predisposition to development of MDS or an AML. So what are the driver mutations genes in MDS? The genes commonly involved in MDS are RNA splicing, DNA methylation, histone modification, transcription regulation, DNA repair control, signaling pathways, and genes involved in the coexin complex. These are the genes involved, and most of these are somatic mutations. And we can, in 90% of the case, if you do an NGS or molecular studies, we can find this mutation 90% of the cases. And even if the blast counts are less than 5%, we can see the clonal hematopoiesis in MDS. And to begin, in earlier phases, most of these mutation happens in the DNA methylation or splicing, or TP53 or cohesion complex. In later phases, they can involve transcription and signaling, apart from involving other mutations also. So this is the table taken from the ASH from 2018, and here we can see the different type of mutation and the frequencies has been described, and we can see that white line is there for SF3B1, and its incidence also mentioned in the bold letter. 20 to 30% is a very commonest, one of the commonest subtype of in MDS. It has a only subtype that has a very good prognosis when compared to other mutations. Either they have adverse or a neutral type of prognosis. We can clearly see that apart from SF3B1, other mutations involving epigenetic regulation or transcription or spliceosome have a very poor prognosis. So this is a table to just for students. I have put this table. I am not going through in detail everything. The same thing whatever I have told before, that has been given here, and we can clearly see that in among the spliceosome category, SF3B1 is the one having the favorable prognosis, and this table also shown the normal function and also the impact of mutation on protein function has been described. One can go through, any students can for later purpose they can go through this table. So it's another study. They have studied about the clonal evolution, the dynamics of clonal evolution, myelodysplastic syndrome. So in this study, the Japanese people have studied around 2,250 patients, and they found out that how the patterns of clonal evolution happens in MDS. So there are two distinct patterns are there, and they found out that those who are having low risk MDS, they commonly have SF3B1 mutation, and those who are having high risk MDS, so they're terming it so-called type 2 mutation. They have a different set of mutations that commonly involves XXL1, TET2 or RAS mutations or TP53. So these are the mutations present in the type 2 in the high risk MDS. So those patients who have been progressed to secondary AML, so they are like telling it as a type 1 type of mutation, and they are having a different set of pattern, and we can see that those mutations are FLT3, PTPN11, WT1, IDH1 and 2, NPM1, NRAS, and we can see that these mutations are very commonly seen in the AML category as de novo AML. So my point was like that when a patient is progressed towards an AML, they will acquire more of an AML type of genetic mutations, and when they are having high risk MDS, it has its own type of mutation, and all these mutation like progress towards an higher disease, and there is definitely a pattern of clonal evolution in the myelodysplastic syndromes. So coming to the epigenetic regulator genes, so in MDS, epigenetic regulator genes are commonly involved, and it is not specific for MDS. It can also happen in the precursor lesions like CCUS and CHIP. The commonest genes that are involved are TET2 and DMT3A, and they are very essential for hematopoietic stem cell differentiation. And if there is an heterozygous inactivation through mutation, it enhances the self-renewal and it impacts the differentiation, leading to the clonal outgrowth of mutant stem cells in MDS. So because of multiple mutations, they can have a different clinical phenotype. So one such mutation of the spliceosome mutation is very important. We will be like discussing about how it happens here. So SF3B1 mutation is a specific distinct subtype of MDS, which is characterized clinically by ring sideroblast, ineffective erythropoiesis and macrocytic anemia. It will lead to transfusion dependency clinically, and it's have a very good prognosis. And in 2020, there is a new drug also been approved for this category, so-called luspatercept. It binds to the activin receptor 2, is the TGF-beta family, where it promotes erythroid maturation and late differentiation. It has been approved by FDA in 2020 for MDS. So what happens in SF3B1 mutation? SF3B1 is an spliceosome. When it is mutated, this protein is supposed to be like cut at the canonical 3' splice site. Instead of cutting at canonical 3' splice site, it cuts at upstream of the splice site, 10 to 30 base pair upstream they will cut. That lead to formation of aberrant transcripts, leading to the insertion of premature termination codon, leading to the decay of this aberrant transcripts. That will lead to downregulation of many genes that are involved in the pathogenesis of MDS. That includes like PTPN11 is involved in the advantage for mutant stem cells, and ABC-B7 where this luspatercept acts. That is the one which is like that is like a reason for ring sideroblast formation, and septin 2 is necessary for impaired erythroid maturation, and MAP3 kinase we know that lead to the hyperactivation of nuclear kappa BI signaling. So when there is a degrade of this nonsense decay happens, there will be downregulation of these genes, leading to the pathogenesis of MDS. Sometimes instead of degradation, some can lead to aberrant transcript, lead to an inform isoforms, and leading to a protein. One such protein is called ERFE protein that will lead to heparin production, leading to parenchymal iron loading. That also adds to the disease process that will lead to iron loading in the liver. Apart from, a patient might be having more increased iron load due to the blood transfusion products, because these patients will generally have blood transfusion dependency. That's how luspatercept acts through these ABC-B7 and decreases the promotes the maturation of the NRBCs in the bone marrow and leads to the decreased requirement of blood transfusion. So the other mutations like spliceosome, the other one is the SRSF2 and U2AF1. These are the spliceosome genes that are like recurrently mutated in various myeloid neoplasms. They are not specific for MDS, but it's having a very interesting pathophysiology. And these spliceosome genes have an interplay with an epigenetic regulation, and they will lead to a pathology of MDS. And when this involved like this, they are generally characterized by poor clinical outcome. And what happens is that, like as we see in SF3B1, these also uses an cryptic splice site for cryptic splice site, leading to formation of premature termination codon in the aberrant transcripts, leading to downregulation of EZH2, a gene that is recurrently inactivated by loss of function mutation in many myeloid neoplasms. So because of these mutations in SRSF2 UTF1, there will be formation of R loop formation that lead to genomic instability, and apart from along with other mutations that lead to the pathogenesis of MDS in these type of cases. So as I mentioned before, this SRSF2 mutation lead to neomorphic splicing site that happens. Because of that, it will lead to formation of an aberrant transcript, and whether it can be translated into mutant protein that activates nuclear kappa B signaling, or it can lead to nonsense decay due to introduction of premature termination codon, leading to downregulation of EZH2 or ACAP8 or ENTS3, lead to blockade of myeloid differentiation or impaired maturation or clonal proliferation of mutant stem cells. So along with that, if a patient is having IDH2 mutation, that is an part of epigenetic regulation, increased amount of 2-hydroxyglutamate leads to DNA hypermethylation that will like lead to disruption of TET2 function, and also it also has an effect on hypermethylation of INST3A that lead to blockade of myeloid differentiation, lead to ineffective erythropoiesis. So this how like have interplay with RNA splicing as well as along with the epigenetic regulation lead to pathogenesis of MDS, and these type of patients generally have a high risk MDS. So apart from these mutations, there are certain germline mutations are also responsible for developing an MDS, and most of these patients will be like present under the age of 50 years. They comprise roughly around 15% of all cases of MDS, and driving somatic mutation always happens in the background of germline lesion that will be lead to more faster mutational rate, leading to progression of a disease, MDS or AML. So it's very important to why we are like saying is because as we know that classically it's been taught like that MDS happens in an elderly patient, but it can also happen in even the pediatric age group. Since I am working in a pediatric age group, we are in referral center. We are seeing almost one or two cases in every month, and we are like transplanting those patients. So before transplanting, we should screen the sibling also, because these patients, the sibling can also have this type of similar germline mutations. So if they are having like that, so if you are transplanting the same disease, same type of this germline mutation, that can again lead to the same type of disease when you are transplanting to the recipient. So we have to keep in mind that before transplanting, we have to do a genetic counseling, and sibling screening should be done for germline mutations. So these are the tables showing the different germline mutations. I'm not going through everything, but one thing I want to specify, this DDX41 associated myeloid neoplasm, we can see that it can even happen at the 6th or 7th decade of life. Though it's germline mutation, it can even present in the older age group. So we should have high degree of suspicion whenever having a VAF of or more than 80%, we should suspect these germline mutations. So it's always necessary, almost nowadays NGS has become a routine platform, even in most of the cities, I think, having NGS platform. So it's good to know about the NGS data, molecular data, so that we can detect these germline mutations also. So coming to the hypoplastic MDS, hypoplastic MDS is a type of MDS, and it has two phenotypes actually. So generally we know that MDS has, if you do a bone marrow, it will have a hyperplastic marrow, but 90% of the patient, but 10% of the patient can have hypoplasia. So if you see the clinical features, immunological molecular studies, we can see two types of hypoplastic MDS. One is aplastic anemia like, and another is MDS like. So in aplastic anemia like, what happens, we will have an inflammation, prevailing inflammation and immune activation. So we'll have increased cytotoxic T cells, and along with mastocytes, pro-inflammatory monocytes, and we'll have decreased TRB regulatory cells, and we have increased prevalence of autoantibodies and PNH clones. So if we see in MDS like, we will have a typical MGS like genetic lesions like cytogenetic abnormalities, and we have clonal selection and leukemic evaluation. So aplastic anemia like phenotype can be like evolved to MDS like. While evolving like that, they will be having progressive decrease in pro-inflammatory or pro-apoptotic immune effectors, and there will be increase in the regulatory suppressive cells, and then can be shift from type 1 pro-inflammatory to type 2 tumor facilitating mesenchymal tumor cells, so leading to the clonal selection and tumor escape. So this is the figure to show that hypoplastic MDS having features of both aplastic anemia and MDS, and there is a clear distinction of an aplastic anemia like phenotype, and another is MDS like phenotype, and we know that this aplastic anemia like can evolve to MDS like if they are having genetic mutations of an MDS. So the main differential diagnosis becomes an hypoplastic MDS is the aplastic Myeloid, because in that also we have severe aplasia. So it becomes very difficult to differentiate, though we are going to discuss this in the next session. But for pathogenesis, I have to mention that how can you differentiate hypoplastic MDS from the aplastic Myeloid. So here comes the genetic mutation studies that can definitely distinguish the hypoplastic MDS from the aplastic anemia. So in aplastic anemia, in at least 50% of the patients, they have uniparental disomy in chromosome 6, and also they have mutations commonly involving P.G.I.M.E.R mutations, and they can also have DNMT3A and AXL1. So we know that DNMT3A and AXL1 are also present in MDS, but if you see that the VAF levels there in MDS, they will have more than 10%, but in aplastic anemia, the VAF will be like kind of less than 9%. So this is the table showing the typical normocellular and hypercellular MDS with hypoplastic MDS with aplastic anemia. So we can see here that the cytogenetic abnormalities will be like kind of present very highly in a typical MDS, and hypoplastic MDS, they have a low risk, but also aplastic anemia also having low risk. But if you see the somatic mutation, the clone size, it is definitely hypoplastic MDS have more increased clone size compared to the aplastic anemia. And we can also see that the type of mutations, the many types of mutations as we seen before, all the somatic mutations can be seen in hypoplastic MDS, but the commonest mutation that can be seen in aplastic anemia are splicing or DNA methylation or chromatin modification, but though that clone size can be very less. So we can easily differentiate based on the somatic mutation data. So a few word about PNH clone in MDS. Apart from the normal pathogenesis of the MDS, PNH clone can add to that pathogenesis and add to the clinical phenotype, and they can also cause some clinical symptoms. And it is good to know about a few things about the PNH clone. So if you see, normally also in the PNH clone is an acquired disease, so as age advances, some patient can acquire these mutations. So in aplastic anemia, 60% of the patients can have PNH clones. In typical MDS, it can present up to 10 to 20%, but in hypoplastic MDS, it has an around 40% cases can have PNH clones. But if you see the PNH clone size, it is very small in the MDS when compared to the aplastic anemia patients. But this small PNH clone can also cause deeper cytopenia and higher LDH level compared to the PNH negative MDS patients. So because of this hemolysis and all those stuffs, even patient can even lead to more hypoplasia and more cytopenias in a typical MDS. So how it happens? Because the PNH clones arise through a multi-step pathogenesis that involves acquisition of P.G.I.M.E mutation in the hematopoietic stem cells and subsequent expansion of this mutated clone. And it is why it happens, because it is spared by the autoimmune attack, because they don't have that typical mutation. They have that immune escape. From the immune escape, they can escape that attack from that innate immune system, leading to the expansion of that mutated stem cells, leading to the formation of that typical MDS clone. So how do you monitor this MDS mutations? So we should do the routine screening, and we can do the monitoring to identify the type of mutation. We have to find the number of mutations, and we have to find at which stage of the mutation appeared, like at diagnosis or during the course or during at the progression. So the size of the given clone can be measured. We give the word VAF, that is nothing but variant allele frequency. Otherwise, it is an indirect measure of a mutation burden. So this is a study which is like done in 2013, where they are telling about that number of mutation, the prognosis. As we can clearly see that more the number of mutation, poorer the prognosis. So as a cutoff, we can see that if a patient is having more than 3 somatic mutation, they will have an inferior outcome, and we can also diagnose this as a MDS. And type of mutation also matters. So when you see the TP53 mutation, it is an independent risk factor in MDS. So if a patient is having TP53 mutation, they will have a very poor prognosis. So in this study, what they have done is they have compared the TP50 mutation in complex karyotypes. As such, complex karyotypes is also a poor prognostic factor. So when a patient is having TP53 mutation along with complex karyotypes, they will have very poor prognosis. So in this figure, we can see here that the graph, we can see that wherever patient is having TP53 mutation along with complex karyotype, they have very poor prognosis when compared to patients who are having without TP53 mutation. The complex karyotypes can do better, and they can reach up to the intermediate stage of IPSS. And apart from the number of mutations and type of mutations, even the amount of mutation, clonal burden, is also important. And especially in case of TP53, when the TP53 VAF is more than 40%, they do very badly when compared to the TP53 VAF less than 20%. So that's how it becomes very important to monitor the mutations in the MDS. Even though how much small it is, they can harbinger the disease progression regardless of the size, and hence it's always important to measure these mutations. And we should, like, whenever the patient progresses or having any new symptoms or cytopenias, it is always advisable to do the mutations, because we can predict which patient is going to progress at earliest. So we have now described about that pathophysiology. Now we have completed the mutations and the importance of mutations and different mutations that are involving in the pathophysiology of MDS. Now we are moving to the next topic, cytogenetics, which is a very important one. And like we told that somatic mutations can happen more than 90% of the cases, but cytogenetic abnormalities can happen up to 60% of the cases. And it definitely have an important role in diagnosing the case of MDS, and also in the prognostication, and also it affects the treatment planning also. So diverse mechanism involved in this type of abnormalities. It involves chromosomal loss, gain, amplification, translocations. And we know that normally conventional karyotypes are used to detect cytogenetic abnormalities. And recently we are using FISH techniques to detect even some microdeletions. In studies and all, we generally they use single nucleotide polymorphism microarrays or array comparative genomic hybridization. So all these techniques can be used to detect the cytogenetic abnormalities. So in de novo MDS, this type of recurring abnormalities happens at around 50% of the cases. But if you see the therapeutic MDS, chromosomal abnormalities increase up to 70%. So these changes can be of numerical change, or it can be a structural abnormality. But however, translocations are very uncommon. So an additional chromosomal aberration can also be happen, that can evolve the course of the MDS disease. And previously a patient can be normal karyotype, and a patient can also acquire another cytogenetic abnormality in the course of the disease, and that can lead to the progression of the disease. So as we said, for mutations, cytogenetic abnormalities are also not specific for MDS, though some are more common in primary MDS, like deletion 5, monosomy 7, deletion 7, trisomy 8, deletion 20, and 17p abnormalities that include 17p deletions and isochrome 17q and complex karyotypes are commonly seen in MDS. So we can use the FISH to detect these common abnormalities. And if you see that therapy related MDS or AML, where deletion 5 and monosomy 7 are more common, and we know that AML have its own de novo AML have its own cytogenetic abnormalities. Very specifically say, some suspect have the typical recurring translocation translocations like 821, 15, 17, inversion 16. If they are happening, it is like more of a de novo AML. But other translocations can seen in all the phases of myeloid diseases, that includes MDS, AML, therapeutic myeloid neoplasm, advanced CML, all shares this type of translocation. So it's not specific, but some mutation, some cytogenetic abnormalities are more specific for MDS. So this is a table showing that different unbalanced and balanced cytogenetic abnormalities, and the table also shows the therapy-related MDS cytogenetic abnormalities, and we can clearly see that deletion 5 is one of the most commonest one. Around 10 to 15% of the cases will have deletion 5q. So among cytogenetic abnormalities, the deletion 5 is the most common one. It incidence around 10 to 15%, and it's a very specific subtype of MDS, and it is a distinct entity in WHO criteria, and it is present. It generally have increased amount of hypolobated megakaryocytes, and with macrocytic anemia, normal or increased platelet count. They have favorable prognosis. They have relatively benign course. They have a lower risk of transformation and good response to lenalidomide. So when the patient were having, apart from 5q deletion, if they are having other cytogenetic abnormalities, that then they will have a poor prognosis. They don't respond very nice to lenalidomide. So what is the pathogenesis happening in 5q deletion? So when there is a 5q deletion is happening, that will lead to haploinsufficiency of the production of certain protein called casein kinase 1A1, that will lead to the clonal expansion of the mutant stem cells. So these casein 1A1 production, half production, will lead to the clonal outgrowth, and if you give lenalidomide, that will cause that will like stop this clonal expansion, that will lead to the that will improve the symptoms of the patient, and even and it will lead to restoration of a normal hematopoiesis. Apart from these things, ribosome biogenesis also, pathogens also involved in this type of diseases. So it will, whenever there is a haploid deficiency, 5q deletion will lead to activation of innate immune system and p53 pathway, leading to defective red cell production and macrocytic anemia. So coming to the monosomy 7 and chromosome 7 deletion, they occur in 10% of the de novo MDS, and they have very poor prognosis. And so if we compare the genes that are involved in the deletion 7, so they involve multiple genes. So when one such gene is MLL3, that actually controls the differentiation of hematopoietic stem cells. So if there is a mutation with MLL3 mutation along with TP53 mutation, that will lead to high risk MDS. So most of these deletion 7q patients will have a combination of gene mutations that will lead to the high risk MDS. The other entity is the trisomy 8, which can also be seen in other myeloid diseases and also in aplastic anemia. And in MDS, it happens generally in the late phases of the MDS, and it involves multiple genes that including DNA methylation, RNA splicing, and transcription factors. So if we are having a trisomy 8 along with c-MYC amplification, that can lead to clonal evaluation for AML. So one interesting point about trisomy 8 patients is that they can present with autoimmune manifestation, and these patients have a good response to immunosuppressive therapies. The other common one is 20q deletion. The incidence is very low compared to other cytogenetic abnormalities. It has a very good prognosis. It has commonly associated thrombocytopenia with high reticulocyte count and lower number of blasts in the bone marrow. In advanced cases of MDS, when deletion 5q is have mutations of AXXL1, UTF1 that will lead to progression of the disease. So there are multiple studies that have found out what type of genes are involved in 20q deletion, but till now they don't have found any significant progress in that area. Though in gene expression analysis have found out that there are some genes that are involved in the regulator of gene proliferation apoptosis that can lead to the downregulation of haploids that can be lead to MDS or MPM. So that's about the deletion 20q. The other common mutation that happens is the high risk MDS is 17p abnormalities. So it is one of the commonest mutation in high risk disease, though in overall it has 1% only, but in high risk MDS 253 mutation happens very frequently. And one type isochromosome 17q that has an intermediate risk prognosis, but the typical 17p deletion have a poor prognosis. So in generally they will be associated with complex karyotypes. And those patients where isochromosome 17 have characterized by presence of severe anemia, they will have a high leukocyte count with neutrophil expressing pseudo-pelgate anomaly, and they will have hypoplastic bone marrow. Apart from that, there can be isolated loss of Y chromosome. If it is present, it has a very good prognosis, and we can also have isolated loss of X chromosome, and it has an intermediate prognosis. And if we are having combination of cytogenetic abnormalities more than 3, then we'll term complex karyotype that are very common in MDS up to 10-15% of the cases. And if the patient is having complex karyotype, they will lead to poor prognosis. Apart from these commonly mutated, common cytogenetic abnormality we described earlier, there are other rare chromosomal abnormalities are involved, including trisomies, inversion, deletions, and it is always a part of a complex karyotype that can lead to the poor prognosis. So the revised IPSS has categorized these cytogenetic groups into different prognostic groups, and we can see that very poor risk, we can see the complex karyotypes, and with a very good group we are having minus Y and deletion 11q, and good prognosis having deletion 5q. Rest are like either intermediate or poor. And we can clearly see that median survival decreases as the prognostic group decreases, and AML evolution also increases. So coming to risk stratification, now till now we have learned about what's the pathophysiology of MDS, clinical features. We have described about cytogenetic and molecular mutations. Now we are going to prognosticate the MDS patient. So we know that prognosis of the MDS is very heterogeneous, and it's very important to prognosticate this patient, which helps in timing and choice of therapy. So in 1997, the working group in MDS, they have come up with this international prognostic scoring system that includes percentage of blasts, number of cytopenias, cytogenetics. Is very simple and very easy to use, and problem with this is like that we cannot use a precise predictor of prognosis, especially with lower risk disease. And moreover, it gives relatively lesser weight to cytogenetics. So it's a table showing the IPSS, initial IPSS, where we can see that it is risk categorization like low, intermediate 1, intermediate 2, and high. And we can see that as the risk category increases to high, we can see the median survival decreases to 4 months, and AML progression happens within less than 2 months. So then came the 2012 revision of IPSS, where they are given more importance to cytogenetics. They are given more cytogenetic data. They have different cutoff points for cytopenias. So now this is the standard tool for assessing the risk in MDS. And so both these criteria are like used commonly in newly diagnosed patients at time of initial presentation. So problem is they don't include molecular profile. And other important thing is in old age patients, this MDS is very common. So if you are not involving the comorbidity data, so we cannot prognosticate this properly, because patient won't die of MDS, but because of the comorbidity, patient will die. So we have to include comorbidity data also, and also that IPSS does not include therapy related MDS or other MDS MPN category. So these are the limitations in IPSS-R. So this is a table showing the IPSS-R classification based on cytogenetic data and blast in bone marrow, hemoglobin, platelet, and ANC. And they have five categories: very low, low, intermediate, high, very very high. And we can clearly see that as the risk category increases, the median survival decreases, and the AML progression also increases. So based on IPSS criteria, this is the table to show that very high patients will have a very poor prognosis with a mean progression to AML is like around 7 months and median survival of 8 months in very high risk. Compared to very low risk, they will have median survival of around 9 years. So there's another prognostic classification system developed by WHO. It's commonly used in European countries where they use WHO category instead of cytopenia or blast criteria, and they also include transfusion requirement also. So it's a very dynamic model. It can be used at any stage of disease, but it is not used apart from Europe, and it is validated to predict the outcome prior to the transplant also. Another system which is commonly used in American groups are MD Anderson Global Prognostic Scoring System. Here they include performance status of the patient, and they use the other depth of cytopenias and blast count. So with this, they have compared with IPSS, revised IPSS, and they found out that when you are applying this criteria, so we can even 25% of the lower risk of IPSS patient can be upstaged. So what they found out that those patients who are in IPSS-R with low risk patients, 25% of the patient actually they do very badly. So they have to be upstaged. So this prognosis system does that very nicely. So it is commonly used in US group. Certain groups are using it, and but not so like IPSS-R, because IPSS-R is very simple to use and it's a very simple data. So most centers does not use this type of criteria except for US centers. So the same center, MD Anderson, they also came up with a different prognostic group for lower risk disease, and they found out that they divide the lower risk MDS into three categories. Those who are lower risk people who are having a category of 3, they will have a poor prognosis compared to other category and 1 and 2. So this can be like same thing. Though with MD Anderson people, they are thinking that we can categorize the lower risk, so we can find which type of disease is going to do bad, so we can aggressively treat those patients. So the latest one of the studies that have included the molecular data and compared with the IPSS revised criteria. So what they found out that when we are applying the IPSS revised risk groups along with the mutations that are analyzed with NGS data, they found out that in P53 complex karyotype, monosomy 5 or deletion 5 are associated with very poor prognosis, and they correlate with the high risk group of IPSS-R. And SF3B1 is correlated with the low risk of IPSS-R. So definitely it shows that inclusion of mutation studies will definitely improve the prognostication, and it will be a part of prognostic tool in the future. So the current risk models does not predict the response to treatment. We don't have any data of those people who are like having HMA, means hypomethylating agent. Those who are treating with HMA, they are failure. Then we don't have any prognostic model to assess that. So, and we don't have a specific system for a pediatric MDS risk assessment. There are multiple lacunae are there in current risk assessment tools. In the future, we might have a clinical risk model that includes this revised IPSS along with somatic mutation data that can give us better prognostication. So how to approach a case of MDS? So we should go as a 4-step stage. So first step is to do the blood counts, to assess the number of dysplasia, proportion of ring sideroblast, percentage of blast, type of chromosomal abnormalities. This is the first step. So second step, to put into the MDS the WHO criteria to fit into which criteria it fits. The third step is to use the revised IPSS to estimate the risk of evolution to AML and expected survival. and fourth step should be molecular profiling. And especially in those patients who are having less than 50 years, we should also include the germline mutations also to predict the prognosis. So this is the table showing an approach to an unexplained blood cytopenia in a patient with MDS that includes morphology and includes cytogenetic abnormalities and sequencing data. So we will be going through the same approach in second session to approach a case of an MDS. So we will be seeing in next session based on this approach. So to conclude my talk, so diagnosis of MDS remains still challenging, and it's one of the first important step to very crucial step in management of MDS. So it needs an experienced hematopathology review of peripheral blood sample, bone marrow aspirate and biopsy, and we will discuss about next session about the importance of flow cytometry, and we know that cytogenetic and mutation data is very much essential. And WHO 2016 criteria classification has been done based on morphology, cytopenia and cytogenetic abnormalities, and molecular assessment is very important. Even for monitoring mutation is also very important, and this stratification is important in predicting the prognosis. So in future we might add mutation data along with comorbidity, age and response to treatment and other performance status of the patient to improve the prognostication of these patients. Thank you.
Thank you. You must be really tired. This was so exhaustive, so detailing, and you went through every bit of it. There is one question by Dr. Munaza. Why is the percentage of ring sideroblast less in case of SF3B1 mutation?
It is not less because they have found out that correlation with ring sideroblast. In those cases, they found when they analyzed the mutation data of MDS, especially low risk MDS, they found out that ring sideroblasts are present, but if the mutation also very commonly seen in those patients. So when they analyze the cutoff data of ring sideroblast, most of these patients have at least a minimum of 5 ring sideroblast. So that's how they came up with this data. So even if you are having 5% ring sideroblast, if you are having a mutation of SF3B1, it is sufficient to call it as this type of subtype, MDS with RS.
Okay, alright. Professor Ashok Malik says exhaustive review on the subject. He is so correct. Wonderfully done, Dr. Murali. Very nicely presented. Very detailed, very nicely done, very crisp. Thank you so much. We will request you to please share the PDF of this lecture. We will pass it on to the students on our Telegram group.
Sure.
Right.
Sure.
And then we'd like to see you in the next session with the detailed the morphological part as well as the other elements.
Yes.
Perfect, right?
Yes. Yeah.
Right. I think you must be really tired. Thank you so much. Good night. God bless you. Take care. Bye-bye.
Yeah.
Thank you. Bye.